Morning, everyone. Sorry that I wasn't here first thing, but I was listening online and it was great to catch the end of the conversation. And I think, Langa, huge thanks for sharing and kicking off that discussion. What I'm going to do is a bit of a mishmash of a session, but in an attempt to come back to Shami's point around epistemic kind of issues and knowledge and how we look after ourselves, who has the knowledge, whose voice matters, whose voice counts, who's listened to. But thinking about that in the context of history, particularly how that influences what we see today when we think about migration and health. So it's going to be a bit of a topsy-turvy, but I'm going to also be pushing you to all engage. People who've done the health course module with me know that we have a session on global health histories and how that links to the ways in which we look at immigration and borders. So this draws on that, but it's not exactly the same. But those of you who I know did the module, I will be expecting you to be quick to contribute to the discussion, no matter how many years ago it was. Now, who's this? Who's this? This. I did think about coming in costume, but I realized I basically wear a cape anyway, so. Any ideas? Anyone online? I'm just gonna, is anyone able to just moderate the Zoom in case? I'm sure you've seen this kind of an image before. And if you haven't, it doesn't matter. Any thoughts? What does it make you think of? Sorry? Black, the plague, yeah, Black Death, yeah. Stanley? Yeah? Anyone else? You read the thing, didn't you? You read it when our colleague accidentally put it up. So this is it's Dr. Schnabel, I believe is how you say it, known as Dr. Beak. And he was a plague doctor in Italy. And this is an image from 1656. Why do you think he's wearing this outfit?
Yeah, I think to prevent himself from protecting contagion.
Yeah, so it's something to do with protecting himself, right? There's also something to do with not wanting to see or be seen, right? Because you're kind of the bearer of bad news. So there's these ways over time that we can actually think about imagery to help us start thinking about how people in the past and how we today might be engaging in attempts to protect ourselves, in ways to think about contagions, in ways to think about pandemics. And I don't have the image here, but you can kind of transpose it. I've got one slide where you then put a picture of a health worker and you're thinking about COVID and you think about 2021, for example. And actually, it's not that different. And the ways in which we don't know what we're doing. And I mean, we've lived through a historical moment in medical history. And we need to recognize that. We lived through this pandemic, this global, what's a pandemic? Anyone? You all heard this word for years. Tifa.
I'm trying. I think it's a global health crisis.
Yeah, so it's global. What's epidemic? What's an epidemic?
Epidemic is a disease which is concentrated in one area.
So that's where you have an outbreak of disease,
yeah,
of an infectious or communicable disease. So a disease that can be spread from one person to another in different ways. And in an epidemic, we're saying it's within one area, right? which could be a very large area, yeah? And a pandemic is when it goes global. So when we're thinking about epidemics and pandemics, what does that make you think of? We've talked about COVID and the Black Death. What else do people think about?
TB showing is
Yeah,
clearly showing.
yeah. So tuberculosis. Does anyone want to remind us or tell us what tuberculosis is? I'm being very deliberate because I know not all of us come from a health background. So I'm just wanting to bring us all to the same page. Anyone want to explain what TB is? Anyone know?
I was gonna say, the way it is for HIV, it's mostly affects your breathing. It's quite the virus. Is it a virus?
It's not a virus. Anyone else?
It's a contagious disease that spreads through coughing. Like when you cough, those small particles can spread to another. So if you're in a room with someone with TB, you can get it. So it's contagious.
And what type of, so we know COVID was a virus, is a virus, yeah? When we talk about influenza, it's a virus. Something, I've been in South Africa for 20 million years, and I still giggle in my head in an unkind way. Here we often say flu when we've got a cold, yeah? But we'll say, oh, I've got flu. I'm like, you don't have flu, you don't have influenza. You're not in bed with unable to walk for 2 weeks with influenza, right? But we use the shorthands of different ways to talk about things. So flu is a virus, right? Tuberculosis is, and I'm kind of now panicking because I know I've got some experts in the room, is a bacterium, a Bacillus type tuberculosis. You see, you can tell that. How long ago did I study this? So it's a bacterium, but it's incredibly infectious. Now, I'm going to come back to, thank you for sharing. Nobody was wrong, right? But the word contagious, I want to keep that in mind, versus the word infectious, versus the word communicable, okay? They all mean the same thing, but they've got very different meanings associated with them, right? So let's just think about those words. So tuberculosis, brilliant. When we say HIV and then we say and AIDS, what do we mean by that? What's the difference? And is AIDS an infectious disease? Is AIDS, what's HIV and what's AIDS?
HIV is the virus, whereas AIDS is the condition where your CD4 count is very low in such a way that it cannot fight any other disease that comes that infects you. Yeah.
So you end up becoming very unwell from particular infections often that wouldn't necessarily make a healthy person sick, right? Or you see particular conditions that we'd often only see in the elderly or somebody who's immunocompromised. And we talk about it being a syndrome, right? Because there's no one symptom, all right? So if you are living with HIV and you're unable to access antiretrovirals, so HIV treatment, it means that your CD4 count, which is a way of measuring how efficient and effective and how strong your immune system is, how well it's able to fight the virus, once that's being challenged too much, it's unable to then fight other infections. And when those different infections all come together, it's what we call a syndrome. So AIDS cannot be transmitted, right? You can't acquire AIDS, but you can acquire HIV, which is the virus. And the reason I'm emphasizing that is, A, we should all be familiar with that language, but we also live and work in a region of the world where we all need to know and understand about HIV, about tuberculosis, right? So it's just important that we get some of these phrases right, because we're going to come back to these issues over the next, what time are we finishing? Yeah, no, at lunch. What time's lunch? So the next sort of half hour or so. So what's going on here? Anyone know what might be happening here?
Sorry to jump in from online.
Yes, go ahead.
Is this the I don't know the exact name, but is this the treatment of mental health issues, like an old one that they thought, I mean, not treatment, but they thought was the treatment. Yeah, but I don't remember the actual name.
No, so it's called, you're right once more. So it's called trepanning. And basically it's been around since apparently like the Stone Age. And it's this idea that by hammering into someone's head, you can relieve pressure after an accident, but it can also assist you if you are suffering from what we would probably refer to today as mental health challenges, mental health difficulties, symptoms, because it was assumed that this would then release any kind of evil spirits or any ways in which your body has been possessed. Now, when we look at this, do we say that's ridiculous? What do we say when we look at that and when we think about 2025?
I would say it's ridiculous, obviously, but I think that one of the interesting things historically when you think of epidemics and illnesses, the gendered nature of it was also particularly interesting because women historically were if they have certain diseases or sicknesses, the treatment was unequal in terms of how men get treated versus women. So I think in as much as we can appreciate the fact that medical sciences has advanced, the sort of epistemic injustices that permeate history but also find their way into the present is something that we also have to pay attention to.
The issues around gender being pervasive when we're thinking about health seeking and the way in which people are treated and listened to. Okay, anyone else? Do you think this dude, because I think it's a guy banging into this woman, do you think the person with the hammer, do you think they had any kind of good points here? Were they onto something? How do we treat pressure on the brain? If you're in an accident and you have a brain swelling or fluid on the brain. Pardon? A drill, yeah. So yeah, a stent. So you either drill a hole or you might actually remove a piece of someone's skull. So in a way, when it comes to the accidents, you know, kind of onto something, right? Not necessarily the best approach to it, but onto something. What about this issue about mental health? Thinking that if I bang into your head, I'm going to be curing you of any mental health challenges you're experiencing. Was this hammering person onto anything? Lydia?
Just looking at it, I don't think so. You only have a headache afterwards.
That is very true. Shamisa.
I mean, in terms of how they interpreted the cause of it, then yes, if we're looking at it in that way.
Yeah. Thank you. Becky? Yeah.
I also think
You're not allowed to cheat, though.
Oh no.
Okay.
Booked it up on AI. I also think that, you know, the understanding that we have about the connection between the mind and the body and physical pain and so-called mental pain, I think it's, you know, there's logic there in terms of the relief that we're having with it.
So some kind of logic around the brain and the head, right? So something about our understanding this idea of not being okay, but in a way that we can't physically see, and somehow knowing that has something to do with your head, your brain, right? So in a way, they are onto something. Yeah. I'm not not saying let's go out and start hammering each other's brains. But really the point here is to remind us or tell us, it comes back to yesterday's conversations about the disciplines, right? And I wish we had a medical historian with us. or somebody who studies the history of social medicine, the social history of medicine. It's something that I do occasionally. I mean, I stopped studying history when I was in grade 8 or 9 or whatever I was. But there are times where I think that would be really cool, because basically you get to go to really amazing museums and look at mad things like this all day, right? But seriously, it's essential we think about it and understand where we've come in terms of knowledge, in terms of how far we still have to go when we're thinking about the human body and medicine and illness and sickness. But we also have to think about who was considered to be crazy in what they were doing, who was taken seriously. What did we laugh off and say, well, that's just absolutely ridiculous, but actually then realize maybe they had a point and they were onto something. So we've got a whole kind of mashup of issues around injustice, potentially, around who's listened to and who's thought to have something worth saying, right? But we've also got this whole thing about history. And history is essential when we're thinking about the disciplines and the ways in which we all need the disciplines in our work. Whether we're thinking about tracing the origins of a concept, yeah? Whether we're thinking about understanding what's come first and what am I trying to contribute to. Whether it's remembering that none of us are doing something brand new. All of us are building on what's come before. And that's correct and that's good. And it comes back to Becky's point. We shouldn't all be claiming to do something brand new. It's basically that's an injustice. That's a form of epistemic injustice, because you're suggesting that you're the only one who's thought of this and those that came before didn't ever do it. Yeah. What else links to this idea of epistemic injustice when we're looking back in time? So when we're thinking of building our question, yeah, for our research, let's say, or we're thinking of designing an intervention, or we're working out how better to do some monitoring and evaluation. What does it mean to think back or not? What are we doing when we're trying to design those programs? Are we bothering to review what's come before? We should, right, to learn from it. But who do we choose to learn from? Whose experiences do we think are worth learning from?
From so-called experts? From experts, so from what we call experts.
Okay, from so-called experts, Tifa?
Also the approach of approaching religious people or traditional healers.
Yeah. Yep. So different kinds of ways of knowing and understanding, maybe. Lydia?
Maybe from people who have done similar work that you are trying to do at that point in time.
Okay, great. So people who've done something similar in the past. Shami?
I think with health, there's the temptation to gravitate towards like a biomedical understanding. And it was interesting with the whole COVID thing, you then found people now paying attention to seemingly indigenous or like herbal type of treatments. And, oh, okay, let's now start testing this stuff because, maybe there's some merit to it. So, yeah.
Anyone else? Anyone else online? Pascalia, I do really enjoy your description online. Sorry, Pascalia said, I don't have a button to raise my hand, but the picture looks like a doctor treating a patient who has mental issues with a hammer, unhappy face, which I think I appreciate. Thanks. Yeah, so it's about who we're listening to, right? So on the one hand, it is about what knowledge is considered important and relevant, right? And how we've moved over time away from this kind of social model of medicine and health and well-being into this more biomedical focused space, right? Where we think evidence means something different than it might have looked before. But what's most important is about who we're valuing and who we're not. And I think this is where we have to think about the sociological context and the history of that to understand why we sit where we sit today. Why is it that we talk about medicine, but for many people, that means going to a biomedical doctor in a biomedical institution? But they might also be somebody who visits a Chinese doctor, who also practices Reiki, who also goes to yoga classes, right? All of those are different and complementary interventions for your health and well-being, but we've been taken over by one particular model. Obviously, I believe in the science of medicine, but that doesn't mean I don't believe in other ways of thinking about health and well-being. But we fall into that trap. It's always the complementary, the alternative, right? It's not, or the traditional or the indigenous, as Shamisa was saying, right? We don't just acknowledge this is medicine. We don't just acknowledge this is about health. And we have to really think about where and why that is, and where this idea then of thinking about epistemic injustice comes in. So we don't need to have a philosophy lecture, which is very good because I am not a philosopher. I had to study. Has anyone had to do or chosen to study philosophy during any of your undergrad or grad classes? Okay, so we know who to ask the next question to. So when we talk about epistemic injustice, and I like this definition here, what do we mean when we're saying it's a philosophical concept? Does anyone want to?
Okay, so it's fundamentally it's about ways of knowing, right? Because there are two concepts that we often use. We use ontology, which means way of being in the world, and then we use epistemology. But within the context of settler colonialism, there are particular knowledge regimes that become undermined as a result of, instituting colonialism and violence, obviously. And so what ends up happening is that some knowledges end up sitting in the margins or in the outer skirts of institutions, So there was a fantastic advertisement that Mad Lemon did a couple of years ago, where this traditional doctor this gentleman came with flu, and then he went to consult, and the doctor leaves the room and he goes into another room and he quickly makes Mad Lemon and offers it to him, and he suddenly becomes better. And then at the end of the ad, there are many people who are queuing outside. And what that ad does is that it shows the relationship between scientific or biomedicine, so to speak, and traditional medicine. And I think what South Africa has done well in many ways, even when we think of traditional medicine, even when it comes to HIV and AIDS, there's been an attempt to try and sort of bring together medical sciences and traditional medicine to counter that epistemic injustice that colonialism and apartheid has carried out.
Yeah. Thank you. And does anyone feel, has that attempt to bring those two domains together, where we might want to talk about the biomedical, and then you were using the word of the more traditional, right? So let's just use those labels for now. Has bringing those together, let's think about the South African context or the context of where you're from yourselves. Has this been successful? Shamisa?
I think not entirely. And sometimes it's because of us as people who have been, I guess, groomed to think in a certain way. So if someone comes to me and they're like, oh no, you should try this herb, I'm more likely to, I'm gonna go to my doctor, So there's this thinking that maybe traditional is less than, and that's something that we've been taught to think growing up. So I think, no, it hasn't been highly successful.
Anyone else? Yes, Langa.
I just wonder if it's not the history of medicine itself, that allows us to sort of have those certain thoughts, the way, I guess, biomedicine has been sold to us historically, just thinking about the power dynamics in the world and how we would think of certain things, that traditional medicine is less and, the biomedicine is more. And then we have come to a place, I mean, if we think about HIV and fighting HIV and AIDS in South Africa and trying to bring in traditional healers and what it means in this particular context, I also wonder if it wasn't per se about, oh, we think traditional medicine is great, but more on, oh, people will go to traditional healers. How do we involve traditional healers in this context? Not necessarily we like you, we think the stuff that you do works, but we need to deal with HIV and AIDS. We know that people with TB or HIV will go to traditional healers. So how then do we bring them to the table, to ensure that people on treatment, take their medication? So we don't really like you per se, but we need you. So let's come to the table and chat.
Thanks, Langa. And I think it is interesting when HIV in the South African context in particular is a kind of, when you look back at it, and I say incredible deliberately, an incredible example of complete confusion about how do we respond to something. Because if you think about, we had the denialism of HIV, right? Which was driven through the Minister of Health, anyway, who then made us think, on the one hand, if I do just have garlic, lemon, and oil, right, and maybe some African potatoes, I'm going to be okay. But in that leading to people's deaths, it also meant that the benefits of those particular food types, which we know are good for well-being and health, right? We know they are, then became ridiculed on the other hand, right? So you ended up with this really terrifying scenario where you were disrespecting everybody everywhere, right? So you had a government that was essentially disrespecting any knowledge generated from the biomedical community, many of whom were working with traditional healers in different ways, going alongside this approach that was actually belittling in itself traditional practice, right? We, many years ago, worked with some traditional healers who were, through the Department of Health, were working with people living with HIV, but also about how to support and encourage people to go for testing. This was sort of in the mid-2000s. And what was amazing is that you really saw that a healer would say very clearly to their client, their customer, their person, I need you to come back with your blood test result. I know there is something going on. I cannot treat you until you've gone and had that blood test. And it created a very interesting dynamic about the importance of those two systems in parallel and the different support that's provided. So no one was pretending to do everything. But, we talk about talk therapy, yeah? The importance of talking. One of the most important things that humans need is to be able to be listened to be heard, to share our challenges, particularly with a medical doctor, right? And that's one of the things that's the hardest to do. Anyone who's gone to the doctor, here I'm talking about a biomedical practitioner, even in the private sector where they charge us rands and rands and rands to go and say hello to someone, they just keep you longer only to charge you more, or they also chuck you out because they get more people in, right? And then you've got systems that are so overburdened there isn't time to speak to someone. Whereas a healer, because of the ways in which their practice works, but also the ways in which, and we'll talk something else at some point, hopefully, around the issue of the commercialization and urbanization of traditional medicine, which in itself becomes a whole other factor when we're thinking about migration and health. But the ways in which actually you have that time to talk or be spoken with, right? So it changes the relationships between the ways that the biomedical and the more traditional sectors provide in a complementary way to each other. So lots of challenges, and we haven't gotten to a point where we're working well together. But we also see how those forms of indigenous knowledge are then commercialized, right? And we know that, I mean, one of the biggest, malaria, for example, right? So there's a lot of treatment-resistant malaria. And there was something that in China, people were using as a natural, as it were, because it wasn't produced by a pharmaceutical company, to treat malaria. And that now is the next frontline treatment for malaria. But does that mean who benefited from that? We benefit if we get malaria, right? If we can access the drugs, if we can afford them, if they get here. But who actually had that knowledge? Where did it go and how did it get used? So this is a whole, topic that we can go and talk about forever. But we have to think about it because we fall too often in the trap when we're talking about health and migration, health. We immediately think in the back of our heads, we are thinking hospitals, clinics, we're thinking doctors, nurses. We might bother thinking about occupational therapists and allied health professionals. But the immediate space, unless we're specifically working on issues around traditional medicine or complementary medicine or other health systems or other health or help-seeking behaviors, we fall into this trap and all of us do it and we need to be really careful about it. We shorthand it. We all need shorthands because otherwise there's too much to say all the time. But we need to remind ourselves that it's never just one thing. And it links to the fact that, health is political, right? Health is a political issue. And it is about our own moral positioning on why we think health is important. And this is where public health sits at a very strange interface because it is based on, it comes from a point of belief and justice rather than necessarily from a point of proclaiming a kind of knowledge generated positivist evidence base, right? Suraj.
Just want to add a comment on the term you said about justice, that saying of public health, but also justice in what sense? Everybody gets the same treatment, equal treatment, that's a form of justice. Or is it getting the best value for money? Is that a better form of justice in terms of using tax money? You might know, but if not, it might be surprising that public health is actually getting best value for your money. If you look at the definition of public health, it's bringing technologies and medicine that brings the greatest benefit to society. So during COVID, depending on the country and the context you believe, for example, in many European countries, the vaccines were only given to elderly population because they were having high comorbidities and less immunity and all those kind of things. Whereas in some other societies, they were not prioritized at all because, don't quote me, but they are closer to the end of their life. Why should we prioritize them in that sense? Or take the case of a disaster situation, which I work in quite a lot. Like you have $10,000 US, you can vaccinate, 1,000 children with vaccine X, or you can use that money to operate serious injuries for 4 different people. Where do you think that $10,000 will go? Most likely for the kids. Is that an injustice to the other person? Yeah, in one sense. But it just in the sense that, this might give more impact. So it's also might be interesting to think about the term justice from whose perspective, whose sides, and how we use it.
Thanks, Suraj. And that is absolutely critical. And it links into histories as well, right? Who was saved? Are we sadder about the child passing away, the mother passing away, or the grandmother passing away? Are we sadder about all the children dying because they can't then work the land for us? Or are we just going to keep making more babies because we also don't have contraception, but we need people to work the land and look after us when we're older? Who gets the heart in a heart transplant? Who doesn't get the heart? Who's had to, I always say had because that's how it felt to me, had to take a course on health economics. So I did. Those of you know how much I love numbers, can imagine how great this experience was for me. But what was phenomenal was going through these different arguments and the value that that Surej was talking about, how the value that governments are looking for. Governments function entirely on cost benefit across everything. They may proclaim otherwise, and they may perhaps in some cases genuinely want things to be otherwise. But at the end of the day, the cost benefit comes in. And this is where we have to remember that what we think is right and just is not necessarily what is cost effective, right? And this is a tension and a challenge many of us across our work always have to deal with, including when we work with a funder, right? We know we need money to do 1, 2, 3, 4, because these are essential to the success of a project. A funder will go, we'll give you a bit for 1 and a tiny bit of 4, collapse it all together and do it in a week. And you said, well, I've asked for 4 years of funding because that's what's needed. Yeah. And it's literally the same. Remember, in health is an exceptional good. Good health is exceptional. There's a constant demand for it. And that's why we can have completely insane private healthcare markets like we have in South Africa. Yes, there's regulation. But the reason the prices are so high and keep going and keep going and keep going is those of us that can afford and are privileged enough to afford a medical aid, or are forced to have a medical aid based on a visa condition, which is often not the best of medical aids, right? When I was a student, I was on the equivalent. And to find a doctor that accepted your student medical aid and things, we know it's a nightmare, but you also knew you couldn't go to the public sector. And when we look at that, that's because the demand for good health will never disappear. And the more money you have, the more you feel if you pay more, you're going to get better care. You might get better care. Maybe it's a shorter waiting time. Maybe the room is nicer. Maybe someone can spend more time with you. But that doesn't necessarily mean that you're getting a better quality of treatment in that moment. But yet when we can pay for something, we demand more for it. So we've also got this challenge where actually we can have a system that's unregulated or a system that's poorly regulated, but the demand's always going to be there. And that's what we also see with, for example, traditional medicine. In South Africa, the Traditional Healers Act is an incredible piece of legislation. I don't know if people have ever looked at it, but it's a really progressive piece of legislation that is saying this is a group of people who provide important services to people in the country, and we need to ensure that they are regulated in the same way that anybody else providing care is. Obviously, the counter argument is, how can you regulate me? But we know that there are, you know, we've got quacks everywhere, right? So how do we get to the point where we're supporting each other in regulating something to ensure that people aren't being harmed? Many countries don't have such a thing. And that's about saying, well, we're excluding you, we're not even engaging. Others would say it's because we're leaving people to get on and do. But I think for the relationship between the biomedical and the non-biomedical sectors, I think it's a really important piece of legislation. So we then move on to something else. What's going on here? So everyone knows Vearey. He's a cartoonist, a satirical, how do you say the word? Thank you very much. Very famous in South Africa, for those of you that don't know. The date here, you can't see it, is March 2025. Just tell me what you're seeing. Yeah.
I think I'm seeing Trump. Donald Trump, like what happened, he had to cut the funds that was like funding the drugs for HIV/AIDS.
So we had US aid funding, right, from the American people, as they often, as the tagline goes. So we had money from the US aid, and it was 2 streams of funding. One stream, which was actually the smaller piece of it, was in a program known as PEPFAR, which was providing antiretrovirals to particularly marginalized groups, right? The majority of the money was going into the actual health system proper, if you want to use that language, where it was supporting particularly district health systems. So it was paying for staff in the system and so on. The removal and abrupt ending of both of those pots of money obviously has led to a crisis that many of us are acknowledging and are witnessing, and many of us probably know people who either now no longer can receive treatments or other services in the ways that they have been able to do previously. We might know people who've lost jobs. We might know people whose families are in crisis linked to both of those issues. You know, VITS alone, I think it was 3,500 people in the end had to be retrenched, fired. It wasn't even retrenchment because there were no packages to give to anyone. And that included everyone from your, you know, those of us working in Messina, the WRHI outreach staff, right through to your kind of senior director type people. So you had overnight literally a complete wipeout of a huge sector of the healthcare system and for particular forms of HIV direct services. So here he's basically saying end to AIDS funds, non-Americans, millions of Africans, go get them, sending out the vulture with AIDS, right? It's horrific. It makes us think that we could have gone back in time, however many years, right? Which we're going to talk about before lunch, which we will stop quite soon, I promise. But the thing that's also scary here is that here it's talking very much about that kind of global north, global south. It's talking about the US and the continent, but it's not just talking about the continent, it's talking specifically about South Africa, right? So we see this. Now, emerging diseases presented a threat, and in this particular paper, to American national security, international development, and global health. What's an emerging disease? Anyone know what we'd frame as an emerging disease? COVID would have been an emerging disease, right? We didn't know what it was, and then it was suddenly there. HIV, as we began to understand what HIV was and realized that actually it had probably been around a lot longer than we thought, but as HIV was emerging globally. And there were a lot of assumptions, right, about where HIV was from, where it was, who was getting infected, and why. Why would somebody present this idea that a disease is a threat to national security? Anyone? Wellington.
Okay, thank you very much, Joe. To partly answer you, I will go back to that cartoon character. It's like in a village context or elsewhere where your neighbor nicodemously sets your house on fire. Then they come with a bucket of water to extinguish, to appear that they are being very, very helpful. This is quite historical. It's linked to the concept of a threat to national security. What a meaning. That's some form of symbolic violence where that meaning of threat, in whose context, to whom is it a threat? So let's go back in time, like we are linking it to what we're just speaking about in terms of epistemic injustice. So we have this HIV and AIDS pandemic. We have knowledge systems that were traditional, and then the biomedical approach. Who then back then decided that this is the most efficient form of approach or maybe antidote to the pandemic? So maybe we could go to the cultural producers who control knowledge. And usually it's Amero-Eurocentric knowledge systems that are privileged. And it speaks to the ideas that were being spoken of legitimacy. You even mentioned that traditional healers, there's legislation around use of traditional medicine. But does legislation entail legitimacy? So if something is legislated, it can still be sidelined and not accepted on the basis of who defines that this is an antidote to AIDS, for instance. So it doesn't mean traditional systems of knowledge failed, but it depends on who has defined
so it
that
connects,
knowledge and practices.
Thanks,
Thank you.
Wellington. So it connects all of those dots back together, right?
Yes.
And just something, because I have to, it's my job, I'm afraid. When you say an antidote to AIDS, is that something that we should say?
It's not, okay, sorry, not necessarily like as an antidote, but as a solution, whether it's from the biomedical and the traditional system where we can have a comfortable
So you're
mix.
talking about treatment.
Treatment, yes.
We can't cure, right? So an antidote would suggest that we can reverse something, yeah?
Thank you.
So it's treatment. And when we're talking about AIDS, remember, we're not talking about HIV. Sorry, I have to do this. It's my job, right? And remember, we all are living and working in a region where we should all know the language of HIV inside and out. We should be literate in HIV. I'm not calling you out, Wellington. It's a general thing. So please just remember to think through, because it's so important in the way that we frame certain things to allow us to have these conversations. And I really liked your point, Wellington, about remembering that just because something's legislated doesn't mean that it's not sidelined. But I think as a step, there's something important about something being marked as valued and recognized. Doesn't mean that it's the correct legislation or the correct approach, doesn't mean that it's being applied correctly, but at least we're trying to have a conversation around it. Can absolutely backfire. But for me, there's something that feels quite progressive about acknowledgement. But I agree. The issue of national, so I'll come to you just now. So the issue of national security, when we first were seeing writing about HIV and the assumed global impacts of HIV, there was a lot of panic and paranoia, where states were seeing HIV as this national threat to security, because there were assumptions around the impact this was going to have on populations, on the numbers of deaths, what this would mean for global trade, what this would mean for world order. So it was a moment where the language of national security, we started seeing in our life, well, actually, probably some of you weren't even born, were you? But anyway, in our lifetimes around HIV. But that language of threat to health and national security has been around since forever, right? So when we think about that, we think about it then being the assumption that this would then impact international development. And again, development for who and what way, and global health. Now, the way, Wellington, you framed it as well, is the language of security for who, security by who, and for what benefit. And there's a great paper, I think it's by King, where that's literally the three questions that he lays out, that is basically like, why are we talking about, in this case, it's health security. Security for who, right? Is it security for me? Is it security for you? Like if I'm this side of the table and you're that side of the table, and I'm coughing all over the place and we think maybe I've got flu, not a cold. You know, should I just be allowed to walk around and sneeze all over you? Or are you going to actually say, Joe, stay that end, here's a mask, yeah? So you're starting to use certain forms of security to think about our health and well-being. I'm going to do a couple more slides and then we'll stop for lunch. Is that okay? So this was from 2002, and I really recommend that you read this article by King. I'll put it in the box. I think I've put them in there if people are interested. So it's a great paper because he manages to tie all of these issues together, right? So he really takes the idea of the post-colonial world in the context of health, in the context of borders, and in the context of security. And he really says, what are we doing? This paper was written in 2002, which is actually 23 years ago. Terrifies me, but anyway. But it's so relevant, and it feels like, I was rereading it yesterday, and it feels like it could have been written today or in 2021, talking about COVID, because things haven't changed. And the political positioning of things haven't changed. So when everyone got their overnight letters, because for most it was literally overnight, from the US saying, you know, thanks for partnering with USAID. They all also said, and God bless America. And I think, again, this really says something about this kind of world we live in around geopolitics. You know, the irony in all of this, because it's not ironic. That's the worst thing about it. It's just absolutely disgusting, right? But the kind of irony of like, oh, but we're good people still. We gave you this money, so we're good, but we don't want to give you it anymore. So, but we were good, even though the ways that we did that money and the ways that we tied so many conditions to that funding and the kinds of work that needed to be done that couldn't be done, particularly around women's health, access to safe termination of pregnancy, issues around sexuality, etc. So we can talk about the kinds of geopolitics of disease prevention continues within the world of health aid and development. So HIV, AIDS treatment will be given there, but not here. So what we'll do is we won't let you into our country because you're living with HIV. And remember, until a few years ago, there were countries that absolutely prohibited the movement of people living with HIV into that country. When the World AIDS Conference was in, where was it, in the US? The irony was that, you know, half the delegates weren't allowed in the country because they were living with HIV, right? So things have changed, but it's very much, we'll send money in your direction, just stay there, stay out of the way. But if you try and come here, we're not going to give you any HIV treatment, right? So also this kind of continued idea of those there, us here. What does the word contagion mean? This is all linking back together. What do we mean by contagion? Does anyone know? So we talk about contagious, right? Yeah. Talk about something being contagious, which for me always sounds a really terrifying word, right? Yeah. Has anyone watched the movie Contagion that came out long before COVID? So often there's another good paper here from 2006, but talking about the ways in which contamination, that language of it's about others, it's about keeping people away, it's about distancing, it's about being fearful of those just off the plane, yeah? They're coming in with their weird language, they look different and they're probably sick, yeah? They bring their weird smelling food. You know, you hear all of this language, but underlying it is something about stay away, yeah? And we still hear that language through the media, which we'll talk about tomorrow. We hear it sometimes in writing, and we hear it in political speak, yeah? We hear it in the global aid world, global development community, not from people who are pro-development work, but the ways in which people are challenging those kinds of norms. It's negative discourse, and it's really about leading us to be allowed to scapegoat the foreigner, right? The outsider, the other. It's that person's fault or those people's fault that we have COVID. It's that person's fault or those people's fault that we have a influenza epidemic. It's that person's fault that they got in a taxi in Maputo and drove to Pretoria, and there was a mosquito in that taxi and they acquired malaria, right? Taxi malaria is like a big thing. We never talk about it, but it's a good example of how it's sort of pushed under the carpet, but it's never the fault of the mosquito who caught a ride. It's always the fault of those people from Mozambique, even though it's very often South Africans returning from Mozambique, right? When we talk about deservingness in the context of health and when we're talking about migration, does anyone have any ideas what we might be thinking about? Now, deservingness is this idea of who deserves healthcare, right? Or who deserves aid, or who is deserving of support. And we know that we very often hear the ways that foreign nationals are spoken about migrants, whether you're from another province, from the other side of town, let alone from another country, whether you're holding a refugee permit, asylum seeker status. But we know that still today, people who are labeled, categorized as refugees and asylum seekers still tend not to be portrayed with any form of agency. The only agency that is given is that you're a criminal, right? If you follow the small boats debates in the around the Mediterranean and these migrants being smuggled from mainland Europe or North Africa into Europe, i.e. France or the UK. And the language that they use would suggest that there's all these, it's a combination of two types of people who are just passive victims who just sort of somehow ended up in these tiny boats that must be absolutely terrifying. Or they're like evil villains out to make money as smugglers. And we know that neither's quite right, yeah? It's more complicated than that. But when choices are limited, the choices you make are still demonstrating agency. And we often forget that. But the only agency provided by the media or the politicians is that, well, they're all on their way to be big criminals. So whether we're talking about somebody crossing from Zimbabwe, whether we're talking about somebody coming to South Africa from Somalia, whether we're talking about somebody coming from anywhere that isn't considered to be a global north high-income country. Even though if we're going to talk about drug smuggling and gun running, we know that those cartels operate beyond the African context, right? But that doesn't come into the debates. So the issue around genuine and deserving versus fraudulent and abusive, as in they're taking things that they shouldn't, needy and helpless, rather than recognizing people are autonomous and independent. So all of this is about a very paternalistic approach on the one hand. Yeah, we'll tell you what you can and can't do because, you know, you obviously don't know what to do yourselves. But it's also about a justification for restricting access to certain services. It's a justification for the way in which others are treated. So when we talk about othering, we're talking about that idea of those there and me here, the others versus me. You're different to me, so therefore you're the other. I'm definitely not the other, I'm the one. And it's about me having my own panic about my own identity and me separating myself from you. So that's where we see, you know, sometimes the language around, you know, xenophobia or anti-foreigner sentiment. Often it's about that idea of a threat to oneself and feeling something that rather than trying to say, oh, life is changing, the world is changing, I'm going to distance myself further and stigmatize you. And it comes out in public discourse, political, legal, media responses. And the most dangerous thing is about the fact that not only does it create, but it reinforces the idea that migrants are different. And it's this reinforcement that is the most challenging thing to undo. We also know that at the level of service delivery, at the level of policy discussions and debates and the generation of policy, how this kind of othering finds its way in. It's very small, so don't worry. But also just to say that there are many different ways that foreign nationals in different ways are positioned as another, that we will treat people as separate, distant, and disconnected from the host community. You often hear, oh, they haven't assimilated. They still cook their own food. They spend time together. They go to their people to socialize. Well, so what? What's the problem with that? We all do that. Yeah. But we'll continue stigmatizing that as a problematic behavior and suggesting that there's something wrong about that, rather than recognizing that by continuing to push an other, we're actually creating poor health for everyone at the population level. And it's essential that we find ways to engage with that and challenge some of this discourse. But it's incredibly difficult. And it's not as simple as, oh, healthcare providers need training to be nicer to migrants, particularly in our context. It's far more complicated than that. Why does othering just exist and in what ways and what are the drivers. And it's far more than simply this idea of a xenophobic nurse or a xenophobic security guard. We know that anti-foreigner sentiments within society are rife in South Africa, but we know that there are many, many challenges within the South African context that affect everybody's day to day. If you're working in a clinic where the numbers don't match the budget that you've been allocated, you're going to get that queue short. You're going to get rid of people as quickly as you can. You're going to lock the doors at 11 in the morning. Who are you going to throw out of that queue first? It's going to be the people that you believe are less deserving. So whether that's somebody that you perceive as living on the street, whether that's somebody you perceive as living in an informal area, whether that's somebody you've decided is a sex worker, a teenage mother, a pregnant teenager, a foreign national. These are all the people who get thrown out of the queue. And the foreign national also in our context equates to speaking Deep Zulu, for example, in Joburg, yeah? Speaking Venda. You're out as well. You're not from here. Well, you tell me you live in a Kureleni, so why are you in a clinic in Joburg? It happens to people quite locally as well. And we've got to be aware of that and make sure that we don't forget those issues and those concerns. So just to end now, and we'll see, we've got the PhD and postdoc and pre-PhD inputs this afternoon, but we might come back to a bit of this on Friday as part of another input if there's time. But I just wanted to end with today with thinking about the word quarantine. So it actually comes from Italian, who knew this, but quattro being 4. So it's about the 40-day period that it was presumed you had to keep people isolated on a boat as they arrived in Venice, in the port of Venice. And the idea was you keep people there for 40 days to see if they show symptoms of plague, right? So this was back from 1377. And the first quarantine was actually established in what is now Dubrovnik in Croatia. And that was in 1377. So we had the language of quarantine, the language of sort of knowing something about infectious diseases, knowing something about communicable diseases, and this idea of quarantine. But at what point did quarantine then become a justification for keeping people away and keeping people separate? So we know that quarantines were often imposed, and they still are today, if we think about COVID, from the result of panic and fear rather than necessarily linked to social ordinances. Or there are regulations generated that are because of panic and fear. So it might be a legislated mandate. And there's this amazing, it's called the Chronicle of the Monastery of Newburgh, and basically they keep diaries. So there's diaries back from 1377 or whatever. And there's this amazing writing around how the inhabitants of this little village, frantic with terror, ordered that no foreigners should stay in the inns. So in the panic, it was like, let's get rid of people. They might be sick, but it's also just getting rid of the numbers of people. And they talked about that the merchants, which was the people who were often coming in by ship, right, should be made to leave immediately because they're bringing the pestilence, which is the plague. So it's back from since forever, and we see this globally, the idea of some form of quarantine, of some form of safety being critical. When we look at Ebola outbreaks in West and Central Africa, the idea of quarantine has been there since forever, right? When you start seeing people getting sick in one village, you actually, often it's literally with logs, people know that you're not supposed to leave that area. It doesn't always work, but it is this idea of containing an outbreak. So we see then that this idea of a cordon sanitaire, so this idea of a corridor that is like a safety corridor for health reasons, like keeping areas separate, and it was armed, and we started arming that from the sort of late 17th century, and this idea being that you couldn't cross it. So we've had the idea of armed people managing the movement of people under the idea of health protection for centuries and centuries globally, and we exported that very nicely, my colonial foreparents, as it were, into other parts of the world, where we know that what then happened was other infectious communicable diseases were brought into those areas, creating obviously multiple health challenges. So we see this throughout the ages. I wanted to ask you, does anyone know where this is? Or when it might have been? So this is Karachi in India in 1897, when there was bubonic plague. And basically they created these segregation camps, but you can imagine who was put in the segregation camps, right? These guys were called plague staff. And their job was either to encourage people to sanitize certain areas, but it was essentially to move poor people who looked different to the white British into areas that were separate from the British, who were claiming India as theirs, right? So you then are starting to see the racialization that is happening across all of this, and you continue to see it. Does anyone know what this is? Anyone know what this is? This. So this was Ellis Island, just outside New York. So when people were coming on the ships to move into New York, mostly from Europe, a lot from Ireland, people were put through health checks, and decisions were made about whether that individual was allowed through or would be returned. Do you think every individual had to go through that health check? So first-class passengers just went. This was only second and third-class passengers. So already you're seeing this idea of who's considered to be sick or not. And these were the symbols that were used on people's cards. So a bit like today, you know, if you're in certain clinics, you'll get red ink saying foreigner, yeah? Or you'll get, you know, on your ID number, foreigners, we get an extra 1 or whatever it might be. So it's ways of seeing who's kind of considered healthy, worthy, or being othered and thrown out. So obviously that practice ended in the mid-1950s, but it is a legacy to how that practice occurred. And now we just don't see it, but it's happening every day. It's happening at airports, it's happening in visa processes. And so we are seeing a different version of this, but it's not disappeared. I will end with this just to say what was going on back in, I can't even read my own, 1905. So this was looking for, this was in London, trying to see if somebody had bubonic plague, because you can look for the bubos or whatever they're called, the big swellings. And this is the photo that I think encapsulates for me most perfectly South Africa's response to Zimbabweans moving across the land border between Beitbridge and Messina. Because even though it's a thermometer, it does look like a gun. And for me, the imagery of that is quite, what's the word? Stark. Because I think this is how many of us see the way that borders are managed in different ways. So I'm going to leave it there. And it's really just about wanting to encourage us when we're talking about issues around migration, borders, health, to keep some of these issues in mind. When you're reading or engaging, think about the words that you use as much as the words that somebody else is using, that I use, that somebody else is writing, that we're reading. What languages are things written in? Who's got the voice? Who's saying what and why? And who's listening to what's there? So Shamiso, you get a breather because Shami's going to be responding to this, but we'll give it a breath. And I think maybe we can kick off this afternoon after lunch with just a few reflections, a bit like we did with Langa's session, before we move on to hearing from our other colleagues.